Gosh.
We got to erase that part. That was rough.
I need to...
Welcome back, podcasting world, with another episode of Core Consult RX Podcast. And today we have two co-hosts. My one and only true co-host, no offense, Tom, Cole Swanson's here with us, and then making his second debut, his comeback. Tom, say what's up again.
Hey guys, I appreciate you having me back on.
Absolutely.
Jinx.
Oh,
gosh.
we got to erase that part. That was rough.
We need to be away from each
Yeah,
other
that
for,
was like
Yeah, we need
for a
to,
little bit.
We need to never do that again. Oh, man. What a great way to start.
I like it.
All right.
oh, that was funny.
So how's life been treating you guys?
Great.
Can't complain.
Cole, I had to talk trash about you a little bit whenever Tom was taking your stead last
Yeah,
time.
I know. I heard.
I know.
Didn't stand up for me at all.
No, I didn't at all.
At least when Dr. Hall was here, you were like, yeah, he's working hard, blah, blah. But, when Tom was here, Cole's slacking.
Yeah, I felt bad about it as soon as I did it. Because it wasn't true.
I was totally slacking,
It's true. You were home playing Xbox, weren't you?
basically.
I knew it.
I wish I was playing Xbox at the
Yeah.
pharmacy, but didn't let you do that.
I came real close to not coming tonight. I worked last night, so
Did you?
my nap turned into like 4 hours, and I was just my alarm was going off. I'm like, oh,
What
man.
is that?
Yeah,
But you made the right call.
yeah. I had fun last time, so
Yeah.
I didn't want to miss it.
So you just finished your 7-day stretch, right?
Correct? Yeah,
Yeesh.
Nice. Yeah, that's rough.
yeah.
We appreciate you taking the time out
Yeah,
of your
man.
sleep schedule to come here and do this with us.
How
Happy
do you
to be
like
here.
that? I had a rotation that was the 7 on, 7 off night shift, and but it was really like 9 on because you had to adjust going in and adjust going out. Do
Definitely.
you have to as well?
Oh yeah. So
Yeah.
today is my poor wife. Today is like the day that she knows not to bother me. I get home and I just need to rest, relax, not do much. I don't do chores or anything like that. I just come home, hang out. I don't mow my lawn or anything, and that way I can relax all day. I try not to nap too long. That way I get to sleep tonight and then get up early tomorrow and kind of reset myself. I used to do like 4, 5 on and then 3, 4 off. And that was worse because it takes those 2 days to adjust.
Yeah.
So really, it was almost like just as I got adjusted, I was going back to work.
Right.
So
Yeah.
I like the 7 off,
Yeah.
7 on, 7 off.
Do you do chores once you get back on?
Yeah.
So I need to find a better excuse because
Yeah.
I don't do the chores necessarily, even when I'm had plenty of sleep. So I just get in trouble. Oh, geez. Okay, so today.
Grown men and we have chores.
I know, exactly. I get in trouble.
I
This is
did.
what happens to you guys.
I'm not allowed to podcast if I don't do my chores.
Yeah.
I was off today. Half the day was spent doing chores. That's the way it is.
That's so funny.
Oh, man.
That's funny. I said it like that, chores.
Yeah.
Yeah.
That's what they're called.
And you guys are like, yep, totally.
That's
Yeah.
exactly what,
Yeah.
exactly what you're talking about.
I
Yeah.
have a list and everything.
Yep.
Oh, man. So today we're going to go through Clostridium difficile infections.
All right.
This is actually from a request from Instagram. So we had like a list of 8 different topics, I think, from the last time I put it out there. And so this will be the first one. We're knocking them out.
Yeah, another poop one. It really comes up a lot with us, doesn't
Yeah,
it?
I feel like it does.
Yeah.
Everybody poops. It's common.
It is true.
That is a great book.
Yeah.
Fun for the whole family.
Yeah.
It is.
Yeah.
Christmas is coming up. So we're going to go through the newest guidelines. They were updated in 2018. And so we're going to run through the guidelines. Not a huge difference, but there is one big one that we need to talk about. But we'll kind of go through the guidelines as a whole and kind of work through. And then hopefully Tom's going to give us some background on his experience treating patients. And then we'll go through the meds. And I get the whole team here today, basically.
Absolutely.
Everything
We
Yeah.
need a nurse and we'll be all set.
Yeah. Right.
So where do you want to start?
Well, I mean, we can just talk about C. diff a little bit.
Yeah.
So it's a gram-positive anaerobic spore-forming bacillus. It's a pretty nasty bug. Usually people are frequently pollinated with it, but with your normal bacterial flora, it kind of keeps it at bay. So a big risk factor for being over-colonized with C. diff and causing C. diff infection, diarrhea, colitis would be antibiotics frequently. Some big ones that the guidelines point out would be like cephalosporins. They bring up Keflex, and also clindamycin's kind of notorious for that. They wipe out your bacterial flora, and C. diff comes in and causes issues. Kind of runs rampant. It's very common nosocomial infection.
And fluoroquinolones as well. That's the other big one.
It's not the first one I said?
You said cephalosporins.
I said the wrong thing then. I meant fluoroquinolone.
So you were right though. Keflex is also.
Yeah,
I think that's
so I
third.
said that twice.
So
Clindamycin is the one you see on the test, I think, right?
Yeah.
It's like the hallmark one that causes.
And it's interesting because I heard an infectious disease doc actually ask my PA students what the most common antibiotic cause of C. diff is, and they all said clindamycin because that's what it taught them.
Yeah,
And
that's what I
unfortunately, he
learned.
was like, nope, and I was like, crap.
Really?
But he was saying because clindamycin isn't used as often anymore as fluoroquinolones,
Okay.
that technically speaking, from just the straight numbers,
Makes sense.
fluoroquinolones have a higher chance just because clindamycin isn't used as much. But theoretically, clindamycin does have a higher chance of causing
Okay,
it.
okay.
It's kind of his point that he wanted to bring. He wanted to bring up the fact that fluoroquinolone use is causing a lot of the C. diff now. So
Okay.
something to keep in mind. But even Keflex, like Cole said, is definitely one. I think they have that listed as third in this one meta-analysis I looked at. So that's kind of interesting too because you don't really think of that causing much problems.
No. I never prescribed Keflex and worried about C. diff, so
Yeah.
that's something good to know.
Yeah, and about 20% of individuals with patients who are hospitalized become colonized with C. diff, and about 30% of those will develop diarrhea. Super common. It's 1 in 5.
And then the other big one we kind of tend to think about, I feel like pharmacists end up getting the bad rap because of this one. We always bring this up, but PPIs.
Yeah.
We
I think
always
we referenced this in the GERD episode, didn't we?
did we?
Yeah.
We may have. But gastric acid suppression in general has been associated with an increased risk of C. diff. However, the newest guidelines say that discontinuation is not necessary unless it's considered like an unnecessary PPI. If the
Right.
person's never tried to come off of it and you think it's probably just overall beneficial for them to come off, then go ahead and do it. But if the
Okay.
person needs a PPI, you don't have to necessarily discontinue it.
I didn't know that. That's good to know.
But that is something that a lot of, during our training, it's like C. diff infection, increased bone bone mineral density loss,
Kidney disease,
all
Yes,
this,
that.
all
Gonna
this
kill
stuff.
you.
But PPIs get a really bad rep for that, but it is something that they did address in the new guidelines.
That was first recognized by the FDA back in 2012 that there was potentially an association, but it's still not hard proof, but it can play a role. But it really goes to the bigger point that if they don't need a PPI, we shouldn't start a PPI.
And I want to clarify, I said I never prescribed Keflex worrying about C. diff, but if you have somebody who is on most antibiotics, and they come in with diarrhea, you got to think C. diff regardless. I mean, unless they're on flagyl or vancomycin.
Right. I think guidelines, to put numbers to it, say something like 3 loose stools in 24 hours, then be thinking C. diff. But yeah, any antibiotic can cause diarrhea, of course. And any antibiotic can cause C. diff, so definitely be on your radar.
How do you kind of break it down, Tom? Whenever you have a patient coming in and they're complaining of having diarrhea, how do you do you always just test for it, or how do you kind of...
No, so it all depends. You always try to find like the baseline of the patient, what's normal for them, because a lot of people are like, "Oh, I have loose stools my whole life," but if they are on antibiotics and they come in and they have new or worsening diarrhea, I mean, it's easy for me, especially because I'm in the hospital. I always order a C. diff, and most of the time they're negative, but it comes back positive more often than you think, and you're glad you ordered it. And
Right.
it's not as bad as you think a lot of the times. You'll have a person with diarrhea and they're not dying of abdominal pain, diarrhea, 100 times a day. It's actually more mild at first, so you'd be surprised at people that do have it, so definitely check for it.
It's good.
Yeah.
All right. What now? Where do you want to go?
Well, like I said, it's a nasty bug. So they form heat-resistant spores, and they can persist in the environment for like several months to years, which is a big reason why so many people are colonized. And I don't really exactly know why, but I always feel like I'm telling people that this is the one thing that hand sanitizer can't kill, right? So you gotta actually wash and scrub.
Yeah, it's actually to remove the spores because
Yes.
the
Wipe 'em off.
alcohol won't actually kill them.
Yep, exactly.
So it's that's why it's so ubiquitous. And about 20 to 40% of patients who have C. diff or diagnosed with C. diff have a recurrence. So recurrence is also pretty common. And they produce 2 toxins. Toxin A is an enterotoxin. Toxin B is a cytotoxin, which they think is partially responsible for the inflammation and diarrhea and issues associated. So that's part of the test that they run. I don't know what specific assays you guys use, because they talk about getting a stool sample, which isn't like the fastest way, but you can also test for the toxins and all that kind of stuff. I don't know if you know.
We do
what they
just
actually use.
a stool sample.
Okay,
And
gotcha.
it says C. diff toxin. It doesn't specify which one, though.
Gotcha.
How quickly are you able to get that back?
It takes a couple days.
Does it?
Yeah.
So usually if they were on one of those antibiotics we just discussed that are high risk factors, the diarrhea is pretty severe, especially if they have a white count. Usually want to throw them on Flagyl or vancomycin. Now vancomycin, not Flagyl, sorry.
That's good. So, like, empirically, go ahead and start the Vanco.
Spoiler alert.
Yeah.
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 Save that for later.
You were just giving us a spoiler alert. We knew what you were doing. But yeah, so that stinks that it takes so long to get it back. But I guess that makes sense to empirically go ahead and treat. Did Cole? I'm letting you kind of dictate where we're going from here.
Well, the last thing I had was that there is actually like a very severe hypervirulent strain of C. diff that's more often associated with the fulminant colitis and the severe cases, leukocytosis, renal failure, all that kind of stuff. And it's the NAP1, the NAP1 strain. I don't think that's commonly like tested for or anything, but maybe if somebody's just really not doing well, they might look into that. And I don't know, it's not going to change treatment or anything, I don't think so. But thought that was interesting.
Yeah, very.
All right, so you want to start going through some of the new guidelines?
Let's do it.
All right, so originally we had this kind of classification criteria that we could call it a moderate case of C. diff versus a severe case, and then from there that would kind of, especially if it was a first or incidence or a recurrence, that would kind of help us figure out which way we wanted to go with treatment. Because for a long time we would use metronidazole as our first line, and then save Vanco for after we've tried metronidazole, or if it was a really severe case. And so now they say that in an initial episode that they consider non-severe is someone that has leukocytosis, but white blood cell count is less than 15,000 cells per milliliter, and then a serum creatinine level of less than 1.5 milligrams per deciliter. Now, the severe is basically just the opposite. They have to have greater than or equal to 15,000 white blood cell count, and then also greater than 1.5 milligrams per deciliter for serum creatinine. The difference is this time around, the treatment options are basically the same. Whereas the person is getting vancomycin 125 milligrams 4 times a day for 10 days, or fidaxomicin 200 milligrams twice daily for 10 days. So they've taken metronidazole kind of out of the equation, especially for the initial episodes.
Yeah, almost completely, really.
Yeah.
What was that second medication you mentioned?
Difficile.
And what class is that in?
It's by itself.
Okay.
Yeah, it's a separate. It's one that we in the past haven't really used very often because it's so
I
expensive.
haven't really come across that at all.
I haven't seen too much from a pharmacy standpoint
I've
either.
seen it one time.
Yeah,
Okay.
that's about
One
one or
time.
two times is about all I've seen it as well.
Okay.
But it is an option, and they list it as an alternative to Vanco.
Okay.
Why would you use that? Some type of hypersensitivity of some sort?
I would think problem with Vanco.
I just read in up to date that it's Flagyl and Vanc are bacteriostatic, and that one is bactericidal.
Mm-hmm.
And so in more severe cases, it has a higher rate of
Killing,
yeah,
basically.
yeah.
I feel like I've heard that too. That sounds familiar.
I gotcha.
Yeah.
It is still brand name only, so it's
I
expensive.
studied.
There you go. I love it.
Prepares a lot more than we do.
It's perfect.
in the car ride on the way over.
Don't text and drive, kids.
Yeah.
But you can study and drive.
Yeah,
Oh,
up to
yeah.
date and drive.
Up to date and dry.
Yeah.
But that one is definitely more expensive, so I think that's one of the limiting factors to it. But if somebody couldn't take Vanc or had already tried Vanc, then that would be definitely an option.
And that 10-day course is pretty standard. They've done some studies into longer courses for more severe cases, and it really hasn't panned out. So at this point, even if it's recurrent and severe, 10 days is still the standard.
Okay. Yeah, that's what I usually prescribe.
Now, where metronidazole is still listed as in the pediatric.
Yeah. So
C.
we're
diff.
focusing on adult, but they
Right.
did put a
So
lot out for pediatric.
I don't. Yeah, I just want to make sure we at
Okay.
least mention that so that they don't we don't get ridiculed.
Yeah.
on
For
that
those-
one. For children, it is metronidazole is still used by mouth or vancomycin, but the 7.5 milligrams per kilogram TID for metronidazole is still a standard for even initial episodes.
And another thing that I think is important to mention is the first thing that the guidelines recommend you do is stop the antibiotic that you think is causing it, of course. Say you're treating something that's a relatively severe infection, but you have to stop this antibiotic. Do you continue to treat the infection plus treat the C. diff, or do you focus on the C. diff for now and leave the other one for later? I don't know the answer to that.
I mean, to me, I would think, and Tom can probably address this a lot better, but I would think that it depends on where you're at in the healing process of the initial infection that you started the antibiotic for to begin with. And then I'm sure, in most cases, you'd be able to find an alternative. If it was a MRSA infection and you're giving clindamycin, then you would just switch to Bactrim or Doxy or something that also covers MRSA, and then take them off the offending agent.
Yeah, absolutely. I mean, Clinda has actually I've been seeing it used more than I usually have in the past for MRSA, especially on outpatient treatments now, because a lot of people have sulfa allergies, Bactrim allergies. Obviously, yeah, you would always stop it. And if there was no other option, you might have to put them in the hospital for a little bit, because if they do have a MRSA infection and you need to give them some kind of IV medication or something that's not available, you'll have to put them in and give it to them, because you can't let the MRSA run rampant while you're,
Right. Yeah. And we started to talk about this before we were recording, but the vancomycin PO is what we use for C. diff. So, it'd be hard to treat MRSA with Vanco IV and also effectively treat the C. diff because the vancomycin is basically unchanged through the GI system and arrives in the gut completely as it was when you took it orally. It actually works really well in that setting. That's the only setting that we would really use oral Vanco for would be C. diff, because we want to get the medication to that area, versus if we need to use it for MRSA, it's not going to get systemic absorption basically at all.
So students, if you ever get pimped about, why is this patient on oral Vanc, there's only one reason. So
right.
Pretty easy answer.
Pretty much.
When you're out there practicing, definitely document that you're putting them on PO vancomycin, because it's more efficient than IV for C. diff infection. Otherwise, insurance will try to not pay for their inpatient stay because they were on PO antibiotics instead of IV.
And you were saying that you've had a lot of issues with that.
Yeah. You have somebody come to the hospital and they're doing much better. They got a dose of IV antibiotics in the ER, or they need PO Vanc because they have C. diff. And the insurance, all they see is that the patient was on PO antibiotics. They could have been home. They didn't need to be in the hospital, and they try not to pay for it. So you have to do a peer-to-peer review where a doctor for the insurance company calls. You kind of got to explain yourself.
What pain.
Yeah.
Lots of fun when you're having a busy day.
Yeah, exactly.
Yeah. Jeez.
It's frustrating.
Yeah.
Which there are instances where you might use, they're more rare, obviously oral is going to be the standard, but there are instances where you might use IV or an enema even. Say a patient has an ileus, then you might consider, and they have fulminant colitis, you might consider a Vanc enema as well. The guidelines mention.
And so we mentioned the initial, an initial infection, treating with either Vanco or Difficile. But if you have a recurrence, that's the other thing where you basically can go back to vancomycin 125 milligrams again if it's the first occurrence, 4 times a day for 10 days. Especially in the case of metronidazole being used initially. I should say, if metronidazole was used first off.
You definitely want to go to
definitely go to Vanc. Now, if you're already tried vancomycin, this is the first reoccurrence, then you can also look at either doing a prolonged tapered regimen or a pulsed regimen. That's the other two things, which I don't believe were in the last guidelines for C. diff.
I don't think I've ever heard of the pulse regimen.
So if this is the case, if a standard regimen was used initially, so they've already used Vanco, then and I'm pulling it up just to make sure I say this right, 125 milligrams 4 times per day for 10 to 14 days, then 2 times per day for a week, once per day for a week, and then every 2 or 3 days for 2 to 8 weeks.
Wow.
Yeah. So I think I mentioned before that even in recurrent, you would only want to do the 10-day. I was wrong. I mean, if it's an initial, then you would do the 10-day, but in recurrent, you can consider the pulse or tapered regimen.
Yeah, so that's if someone has already tried, they're just the regular 10-day regimen the first time around, or if they gave metronidazole the first time, then you would just start with the normal Vanca for 10
Okay.
days.
When I was fresh out of school, I remember doctors would give patients just a refill on the 10-day flagyl and saying, the spores, sometimes you don't kill them all. You need to take another course. But that's good to know that if it recurs that you need to do this.
Which I think you still can, because even the guidelines give the pulse and tapered recommendation, low quality of evidence, weak recommendation. So I think it's just, kind of another option to consider, as well as if you did Vanc the first time or flagyl the first time, you could try fidaxomicin this time with a standard 10-day regimen.
Maybe they're immunosuppressed or something.
Right.
Like, okay.
So they give you a lot of options in the recurrence situation.
The other thing we didn't mention is in the case of an initial episode where it's extremely severe to the point where the patient is hypotensive, or they're in a state of shock, or they have like megacolon or something like that, then we would use a much higher dose of vancomycin, up to 500 milligrams 4 times a day, and that can be given mouth or nasogastric tube, and then still done for the regular amount of time, but with a much higher dose, because obviously it's a much more severe infection.
Okay. Yeah, usually a patient like that would be in the ICU.
Yeah.
NG tube in place, probably on the vent.
And I guess they may have, the institution might have guidelines that they would want you to follow. Yeah. Who knows, might be a little bit different or might be the same. So
usually the bigger the hospital, the more guidelines.
Right.
Yeah.
All right, what else for this?
That's the main stuff for treatment, really.
Yeah.
It's really not that for the first occurrence, as long as they're in good shape, it's really pretty easy. One thing, I like it.
Yeah.
When it comes to antibiotics, usually it gets a little more complicated than one thing or two things.
So they also have an option where if the person is having recurrent C. diff infections, where you can give vancomycin 125 milligrams 4 times a day for 10 days. Okay. And then you give rifaximin, Xifaxan, 400 milligrams 3 times a day for 20 days following the 10 days of vancomycin to hopefully ward off any other GI remnants of the C. diff.
And that's one thing they're looking into. They're looking into another couple of antibiotics that haven't been FDA approved yet that I think they use in other countries, and the names are escaping me, but there might be some other options in the pipeline. But actually my favorite one, which I almost forgot to mention, is the fecal microbiota transplantation, which is the poop shake, which I've definitely referenced before.
Okay, is that where people
Yeah.
take someone's poop in a pill? And
basically,
okay,
yeah. I mean,
poop in a pill.
That's what they do. And, the guidelines give this a strong recommendation, moderate quality of evidence. So it's pretty good. If somebody has had recurrent C. diff and you've tried many of these options, I think they say more than 3 occurrences, I'm pretty sure, you can consider this. And I think I used to say that you could drink the poop shake because that sounded so much better. But now so there's a couple ways to do it. So it's made into a suspension, and it can be given up to down is what they say. And so that's either in a nasogastric tube or a nasoduodenal tube, or back up is the other way. And that can be through a colonoscope or as a retention enema. They can do that. And the idea is to basically, your microbiome has been wiped out by these broad spectrum antibiotics. C. diff has taken over, and this is to replace your gut bacteria to try to help suppress the C. diff, basically, is the idea.
I did not know that.
So
That's
the poop
good to know.
shakes, I like them. I think they're relatively
I don't know if
the new kids on the block.
I don't know if you guys are getting to this, but do they mention any other like probiotics like lactobacillus or no?
So that's the big kind of debate is while there are people that have used them for recurrence, there's not like great evidence that shows that it's highly like effective or not. So like the new guidelines didn't give a recommendation for them.
Okay.
So sometimes people might use them along with the antibiotics that you're using to hopefully, reduce a diarrhea day or something. But in C. diff, there is actually there's at least one good trial that would be good to mention that's escaping my mind now. But it's not the data is not as strong as you would like in those. But I think it's coming because I think that they have a role to play, especially if this is all about the microbiome. You would think they would definitely have a role to play.
And the more, you learn about the microbiome, the more you realize, it's
fascinating.
It really is. It makes you wonder,
I feel like decoding the microbiome is going to be the equivalent of the Genome Project.
Absolutely.
Honestly.
Because what are we, outnumbered 10-1 or something by bacteria cells?
That's what they say.
Yeah, that I've heard theories where we're, host for bacteria.
That's our whole
Yeah,
purpose.
They're controlling our lives.
Yep.
We should do an episode on the toxoplasmosis that you get from like
Yeah,
cat
it, like
poop and
changes
stuff.
your
Yeah, like your brain chemistry and the way all sorts of stuff.
Oh,
that
I
they're
would love to learn about
theorizing
that. That sounds really
I've
interesting.
even heard that a lot of CEOs and like people who are more associated with like risk taking and things have positive
Infected, yeah.
positive for that.
Toxoplasmosis.
No way.
Toxoplasmosis, yeah.
It's apparently potentially bad. It's potentially teratogenic. So if you're pregnant, you're supposed to stay away from like cat feces and stuff like that.
Yeah, that I knew, but I didn't know it.
But it's because
changed your
that's the same. It's
personality.
the toxoplasmosis. It's the same bug that, and there's a lot of theories about other issues it causes. So yeah, we should totally do
Really?
one on that.
Yeah.
That'd be pretty fun.
I tend to stay away from cat feces anyway.
yeah.
Even when I'm not pregnant, but
I
like
love that stuff. I don't know what you're talking
can't
about.
get enough of it. The other thing we got to mention too is the new monoclonal antibody that's been put out for C. diff reoccurrence. Bezlotuximab was approved, I think, late 2017.
Okay.
But it is approved for the recurrence of C. diff that's already been treated with an antibiotic, and the person is still at risk for a recurrence. There was a couple of different trials that have looked at it. I've seen numbers kind of all over the place as far as the percent that it reduces your chances of having C. diff again. I've seen initial studies say up in the 40% range. I've seen some other ones that say only 10%. So I think it definitely is an option, but it's a single infusion over an hour that the
Okay.
patient can get.
So it's not a chronic medication.
Just
okay.
one time
that's pretty
infusion,
easy.
single dose.
Okay.
So it's expensive though.
Can you repeat that name again?
It's Bezlotuximab.
Okay.
I can't remember the brand name. We'll find it in a second.
I'll have to go back to this podcast and write it down. Yeah.
But
Spell it out for everybody.
but they do have a precaution if somebody has heart failure. Apparently, it can
Okay.
cause an exacerbation. So they want you to use a lot of caution if somebody does is considered to have heart failure. And then, like I said, the cost is the other big one.
Okay.
So something to kind of consider with that. But if somebody has insurance, they can pay for it. Then it
Yeah.
may not be a bad idea.
Yeah.
Zenplava.
Zimplava, that's right.
Zenplava. Yep.
Yeah, if it's a recurring issue,
Yeah. So definitely something to kind of keep in mind.
yeah. And with C. diff, it's hard. Patients are usually, upset, understandably, because they get put on these antibiotics and they continue having diarrhea. So it's good to warn them, like, listen, we're killing the infection, but the antibiotic's still going to give you diarrhea. That's why I always add a probiotic. That way, at least I can say I'm trying to help it,
Right.
resolve as quickly as possible. But it's good to warn the patients that as long as you're on the antibiotic, your stools are probably not going to be normal for a while.
And that's a good point because they might ask, well, what can you do for the diarrhea while I'm on this antibiotic? And the guidelines really recommend against using loperamide because you don't want to stop it all up. You want to, keep it moving, basically.
Great point. Yes, very much so.
I'm actually a big fan of, even for like the community pharmacists that listen, you have someone that comes in the pharmacy and they say they've had diarrhea, for a day or two, and they want you to give them something over the counter. When I worked in just regular community pharmacy, I was a big fan of telling them not to use Imodium or loperamide because, one, without any other knowledge of what's going on or any other labs or anything like that, you have no idea what's causing it. And so I would always just encourage them to get like Pedialyte, even if it was an adult, to stay hydrated, keep their electrolytes up, and then just let it run its course.
Yeah.
Because if you, like Cole said, if you stop it up and you don't know what's causing it, you don't know if they've been on, they may tell you they haven't been on antibiotics, but maybe it was from like a couple weeks ago and they're just not
Right.
telling you.
Yeah. How many patients? Yeah.
You just
know their meds accurately.
Exactly. You just, I never would take any chance, and I
No.
would always tell them not to get I almost said indapamide, Imodium.
Yeah.
You got that evidence-based stuff on your brain.
Yeah, I'm okay. But so I would always encourage people not to get loperamide over the counter.
I mean, no, I haven't been on antibiotics recently. I had Cipro a few weeks ago for UTI, but no
Right.
antibiotics,
Yeah.
Yeah. Exactly.
Exactly.
Yeah.
So that was always my rule of thumb personally. I don't know if Cole, if you did the same thing.
No, I think that's a good rule of thumb. Usually that's if somebody's having diarrhea, stay hydrated, make sure you got electrolytes. If it's more than a few days, then I would
get
see
seen.
somebody. Yeah.
With when they're inpatients in the hospital, if it's pretty suspicious of C. diff, I definitely, obviously, will never give them a dose or put it like as a PRN medication. But if it's very unlikely and the patient's having rough diarrhea, you still test for it, but sometimes I'll give them like a one-time dose just to help them get a couple hours sleep together. Usually it doesn't help that much, but it makes the patient feel a lot better. But
Right.
that's only in cases where it's very unlikely. You're almost positive that it's not C. diff.
Right.
Usually patients who are already on Flagyl or...
And it makes sense.
Yeah.
It makes sense too, like for in your situation, because you have all the information.
It's much easier.
I've
in my
seen a lot of
position. Yes.
I've seen a lot of pharmacists that try to make that call when they don't have any, and that's
Right.
why I definitely
Yeah.
always in that situation would say like, just hold off. They're not going to die from it.
Because we are flying blind in the community pharmacy.
Unfortunately.
Well, I mean, I have so much respect for all the anybody who works in an outpatient setting, because I do realize how lucky I am to be able to just order a lab and a chest X-ray or a CAT scan of the belly and get the results and not have to worry. Oh my God, is this what's going on? Now they're going home on this medication that could possibly be hurting them. So it's definitely a more cautious field when you're working in the outpatient setting.
And I'll mention this study real quick that I just pulled up. One of the reasons why they're getting away from metronidazole is because there was a study that came out that compared basically the 30-day mortality in patients with C. diff when they looked at vanco versus metronidazole, and it was reduced with vancomycin comparatively. And I think that's was one of the drivers for the new the new guidelines.
And the reason that they were ever using Flagyl in the first place is basically there were two randomized clinical trials from the late 80s, early 90s that compared Flagyl to Vanc, and they found that there was no difference. But there were like less than 50 patients per study arm, and both of those studies really wasn't high quality evidence. And since around 2000, they've done multiple placebo-controlled studies that all have shown that Vanc is better than Flagyl, like Mike was mentioning, and in severe or fulminant colitis, C. diff, Vanc is also better. So that's why they made this change in recommendation.
And if cost is still an issue that you're kind of having in the back of your mind, oral vancomycin has come down quite a bit. It's available generically. It's also available in a solution now called Furvanc, and that's relatively cheap compared to the thousands of dollars that it used to be for oral Vanc. And it's also, you can get compounding kits. Like I think that company First, they has those compounding kits. I think they have one that has vancomycin. And then there's also, if, worst case scenario, you can get the IV solution and compound that with just like regular, what is that, like or sweet or whatever that stuff is, and turn it into the
base.
And turn it into an oral liquid solution from the IV solution. You can do that, and it's okay to do it that way.
Oh, that's
so
interesting.
Compounding pharmacies can do
Very
that.
Cool.
So there's a lot of different options. So if you are worried about the cost, you can usually find it for a patient relatively cheap.
Okay.
And that Furvanc is, ever since that came out, that's what I've seen more so than even the oral Vanc, because it's pretty cost effective.
Right.
I haven't prescribed Vanc by mouth outpatient yet, but I used to have so much issues that, as soon as the person went to fill it, it was way too much money. The insurance wouldn't pay for it. They said just use Flagyl. So I'm wondering if they're aware of this now. I mean, hopefully they should be.
I mean, it's only from
yeah, right. I'd be surprised.
It's from February, and I mean, I think I've still seen a lot of Flagyl. I had Flagyl. It was somebody for C. diff, and they had Flagyl. And the next day they started Vanc, and I was like, that's kind of weird. Maybe they caught on, or maybe I don't know. So yeah, it's takes a while for stuff like this to catch on.
And I think that's why the guidelines specifically have a little blurb in there, like if the person was given metronidazole initially, go ahead and give them that vancomycin, the regular initial dose, because it probably didn't do anything.
Yeah,
so.
yeah.
Which it's still, I mean, Flagyl still works, just doesn't work as well.
Yeah.
Don't work as well.
So they're anticipating people not reading the guidelines.
Yeah. Exactly.
They've learned.
Which the guidelines also, they talk about, this was carried over from the old guideline, but contact precautions while you're in the hospital. I'm sure you run into that a lot with patients with C. diff, but, isolating them if you can keep them on their own toilet, then that would be great. And then you have to wear gloves and gowns and all that stuff, right?
Yeah, those are the pain in the butt ones where you got to put the gloves and gown on. But, it's worth it because you do not want to get C. diff.
No.
Yeah. I'm with you.
Which is funny because, lady walks up in the pharmacy, she's holding her stomach. Oh, I'm getting my oral vanc, blah, blah. And I'm like, I'm just going to wipe down the whole counter now.
Yeah.
I feel like that's a good thing to mention to patients. You might want to stay away from people for a little while.
Yeah. Those are the ones I wash my hands, especially.
Yeah.
With soap and water.
Yeah.
Not just
hand sanitizer.
Not just hand sanitizer because that won't do the job. You actually have to wash and scrub the spores off.
Yes, that's right.
Good little other clinical pearl to mention, even though hand sanitizer, especially in hospitals, is usually the way to go.
And we mentioned earlier on, but the diagnostic tools that we have, there's the guidelines actually have a table listed out with all the different diagnostic criteria, the assays that you can use, and then where that data comes from as far as which one's better than others or which one has the highest sensitivity or low specificity, and it explains it and has a really good 2-page explanation of which ones to use. So make sure you check that out if you're one of the providers listening.
I really like this guideline actually because the whole thing is set up like an FAQ section of a website. It just asks questions and then gives answers, and then below that it summarizes the reason they gave those answers.
Yeah, it
Well
makes
put together, I think.
I like a lot of the guidelines that have the question should we blah 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 blah, and the answers so much easier than reading all the the information.
And where are you guys reading this guideline?
These are IDSA. IDSA
Society
guidelines.
of America.
2018. I think it was
February or March.
Yeah. IDSA.
What do you join kind of annually?
No, it's free online.
Really?
So
Okay.
Yeah, you can download the PDF file of the guidelines.
This
It's
one
like
came
100 something
out-
pages long.
This one came out, February 15th, day before my birthday this year. So if you Googled updated IDSA C. diff guidelines or 2018 IDSA C. diff guidelines, that'd probably come up.
Because that helps a lot. Because up to date will tell you the right thing to do, but sometimes it won't lay out. Because until you told me that vanc is reduced mortality, I didn't realize that.
Well, even the up-to-date guideline, the up-to-date, I think, article mentions metronidazole as an option still, and they kind of don't put enough emphasis on taking it out.
So does Medscape. So
Yeah, right,
I know
they
a
do.
lot of
That's
people
right.
look at Medscape, and it's still listed too.
So one good thing about Medscape that I will say is that's actually who notified me as soon as these guidelines got released back in February. They sent me an email just saying new guidelines for C. diff. That's what made me, because I did a Alexa flash briefing on this a long time ago.
Okay.
But they had mentioned that when it first came out, and Medscape, I believe, is free to sign up for.
Yeah. Oh, yeah, it is.
And you pick your specialty, and so I signed myself up for all the specialties.
Yeah.
And they could just send
you
me
have to.
emails for
I mean,
a bunch of things.
yeah.
So I mean, if that's the quickest way to get it without having to search
I'm gonna
guidelines
join
each
when I
day.
go home. Yeah. I mean, I use Up to Date, and it's an amazing site. I definitely recommend it, but it's a lot of money. So
Yeah, it is a lot of money.
yeah. If your job's not signing you up for you, go ahead and use Medscape. I would say.
Yeah. Anything else, gentlemen?
I got a quick note. So if just to run down, I had an ICU patient with C. diff, and just they came in with severe bacteremia. They were on vancomycin. They had to be intubated. We had to put an NG tube in. They were having so much diarrhea. So just to kind of show you how they get managed when they're almost getting to the part, severe C. diff or fulminant colitis. They're sedated on the vent. They have an NG tube. We had to use oral vanc, and unfortunately you got to use things like flexi seals and rectal bags, because otherwise the patient's having so many loose stools, they get skin breakdown. So these are things that you don't learn until you get out there. So just to give all the future providers out there a heads up that
That's
a couple little
perfect.
things.
Absolutely.
Yeah, flexi seals, they're amazing on patients who can't control their own bowel movements, and you're worried about skin breakdown if they're going to be supine for a prolonged period of time. So that's a good note to end on, right?
Yeah, no,
Rectal
that's-
bags. Yeah.
No, that's
terrible.
good though, man.
Yeah.
I appreciate that.
The only other thing I wanted to mention was there is actually there's a couple studies that potentially link Remeron and Prozac to an increased risk for C. diff. So that's kind of random, but I came across that.
Say that again.
Remeron, like mirtazapine,
Yeah,
antidepressants, and Prozac, small link to potentially increased risk of C. diff.
Really?
So, yeah, I don't know.
I
Don't
see
ask me
Remeron a
why.
lot, yeah.
I don't know if it has something to do with serotonin, but
I mean, there's
Possibly,
a ton
right?
of serotonin receptors in the
Yeah.
gut, so that would kind of make sense. But I would
Right.
think it would be all SSRIs, or is it maybe because fluoxetine's half-life is so long?
so long.
I mean,
don't know.
SSRIs, that's one of the main reasons they call it diarrhea, right? Because
They can cause stomach upset, especially at the beginning because of all the serotonin receptors in the gut, for
that's
sure.
pretty interesting. Maybe we'll touch on that another time.
Yeah, for sure.
Yeah.
We'll need to look into that and find a mechanism.
Yeah. Well, hey guys, I appreciate you having me.
No, absolutely, man.
I learned a ton. You guys are the best.
No, we appreciate you
Appreciate
taking
you
the time to
waking
do
up
this.
from your nap and coming on.
Yeah,
for
yeah,
sure.
yeah. Sorry if I had some pauses there, staring off in his face. I was taking micro naps.
Yeah, micro naps.
We take them all the time.
yeah.
It's all we do because Mike doesn't actually sleep, so his
That's
life
not
is
true.
miniature 10-second micro naps, pretty much.
You just get enough of micro naps in your day, and you don't have to sleep. You
Go all
don't
night.
have to give up 10 years on the end of your life.
Yeah.
Basically an ad for Monster.
They're the worst years.
What are you going to do? All right, guys. Thank you so much for listening. And we will be back again soon with some more, hopefully covering some more topics that we got off of the Instagram followers. And if you guys like the podcast, make sure you subscribe, leave a comment, and then let us know if you have any comments or anything like that you want to add or any topics you want us to cover. Feel free to email us or hit us up on any of the social media platforms. And we will see you guys next time. Take it easy.